Kalimera. Good morning. Welcome to session 1 of our Menopause and Women's Health event, Your Fertile Years and Beyond. My name is Christiana. I'm the Scientific Director and Head of Fertility Services at the ISIS Clinic, and I'll be the moderator for today. The event is sponsored by the ISIS Clinic and supported by AIPFE Cyprus Women of Europe. Our main aim today is to highlight the importance of evidence-based information surrounding women's health from puberty to the menopause. Before we begin, I'd like to extend a thank you to all of you for being here today. Please note, we'll be opening the floor for questions at the end of session 1, so if you have questions along the way, please make sure to jot them down. It's now my pleasure to introduce Dr. Mavrides, the Medical Director of the ISIS Clinic, consultant obstetrician and gynaecologist, and expert in women's health and fertility.
Okay. Thank you, Christiana. Thank you. Good morning, everyone, and welcome to our Menopause and Women's Health event. Thank you again, people who attended, the speakers, especially ones traveling from abroad, our guests, colleagues, and the organizers here. Menopause, perimenopause, climacteric era. What is it? When does it happen? How it happens? The effects of it. Do we really know what's going on? Do we have all the information? How are we defining it? We need to take a step back and look at it from a social point of view and get everyone related to help. The healthcare professionals, doctors, nurses, psychologists, nutritional specialists, physical educators, trainers, politicians, advocates, for all this. This meeting is about menopause, and it's mainly to educate, inform, and raise awareness. Menopause, it is here to stay. It will be more and more of an issue to manage in the coming years and decades. In Cyprus, a population of 1 million, around, we have 100,000 women in menopause, so it's about 10%. 25 million women per year globally will be entering menopause every year. By 2030, which is in 4 years, by the way, 1.2 billion women is estimated to be in menopause. That's about 10% of the population. This percentage will be going up and up as life expectancy gets higher. So it's therefore crucial that we advocate for comprehensive access to all types of treatment and menopause support. It's crucial to do that. A 40-50-year-old woman now is completely different from a 40-50-year-old woman 30 or 40 years ago. The dependence on others, the independence of a woman, the role, the expectations, the relationships, single parenthood, all these are changing. And most of all, as we said, life expectancy. At 40, you're halfway in your life, maybe even less. And at 50, you're starting to enjoy life. And that's how it should be. On the other hand, biology is biology. Okay? The hormones, talk about the hormones. Is that the root of all evil? Far from it. Is it the stage of life? Is it the children growing? Is it the empty nest phenomenon? What about the libido, the relationship status, the financial work status? All these factors. Men go through the midlife crisis. We describe men going through the midlife crisis. Is this the midlife crisis for women, and we've just labeled it as menopause? I've been thinking about this the last few days. Probably I thought more about menopause in the last few days just because of this event rather than in the past few decades in my career. And it seems that we've attached a medical diagnosis because menopause, it's month, pause, stops. So the monthly routine or the period stop. It's easy. We've defined it. That's it. But it's a much bigger problem. So I think we've labeled. We have a medical diagnosis of menopause, which is easy to define, but we're trying to tackle a social situation, a social problem, or a stage of life for women. So I think that's where the confusion is. So all these cause a state of insecurity, and of course media can mislead or exaggerate. The social networking, it's all automated now. The more you click on it, you've got the algorithms. The moment you hit 40, it starts pumping you with the menopause, perimenopause. Everybody's becoming an expert now, tackling it and approaching it from various aspects. So there's a general sense of confusion out there. I think there should have been more men here to hear about it because they are part of this social issue or stage of life. Anyway, I don't want to hijack the talks. Thanks again for coming. I hope you have a great day. It's a beautiful day outside. And by the end of it, with some extra information and knowledge about this subject. Thank you.
I'm very excited to introduce the next speaker, Professor Joyce Harper from UCL, the Institute of Women's Health. Joyce is an award-winning scientist, academic, and expert on women's health, fertility, and menopause awareness.
Perfect. We do have a lot of women in the room, and it's a fantastic vibe. How are we all feeling? Great! Woo! Right, we're going to have. I know we need more men in the room, but today it's about the women. So we are going to have power in this room today, and we are going to power ourselves with education and learn more about our bodies. And I want us all to leave here today with a little bit more self-love and a little bit more self-care. And I know, especially in Cyprus and in Greece, women, we spend too much of our time looking after everybody else. We spend our entire time looking after everyone else. And in the menopause, post-menopause stage, I want us all to have permission to spend more time looking after us and enjoying our life. Yes, well said. That was a good heckle. That was a really good heckle. He's saying, not yet, not yet. Let my mum look after me a bit more. But no, we are going to get there. So I've been working in this field for a long time, almost 40 years. And I have always been very passionate about educating people. And I first started working in a fertility clinic in the 80s. And when I went to the clinic, I had a BSc and a PhD, and I got there and I thought, I'm learning all about fertility, and I don't know this already. Why don't I, as a 25-year-old woman at that time, why didn't I understand how my menstrual cycle worked, how my fertility worked, and my periods, and my menopause? Wasn't even discussed in the 80s. There was no such thing as the menopause in the 1980s. But it really was so obvious to me that we were not teaching women about their fertility and about how their body worked. And I started writing a book then, but I didn't finish it until 2021. But I wrote a book called Your Fertile Years, and I've just finished a book. It's going to be out by the 1st of May, called Your Joyful Years. And for this book, I interviewed 50 women over 50 who were all thriving and happy, and I wanted to share their wisdom about how we can live that happy life of self-care. We need to see other women doing it. We need role models. If we can't see this happening, it's not going to happen. So I'll tell you a little bit about the book, but it will be, I'll come back to Cyprus in May and talk to you all about Your Joyful Years. The subtitles, Empowering Good Health and Happiness Beyond 50. Okay, we've got this. We've really got this. It's our time. Now, as you said, our grandmothers and our mothers didn't lead the life we're living now. And now we are going to do it. We are going to live longer and healthier than women ever have before. It's very exciting, very, very exciting. So a little bit about some of the work I do. Education has obviously been a big passion, but I did, Christiana knows, I did many other roles in between them, did a lot of lab work, etc. But I now co-run a UK education program called In Tune. We want women to be in tune with their bodies, in tune with each other, and specifically at the moment we're working on menopause, so we want them to be in tune with their menopause. So I'll tell you a little bit about that. But also, in 2019, I set up an international reproductive health education collaboration because I realized that we need to make sure globally that everyone is aware of their reproductive health from puberty to the day they die. And Christiana is one of our members on our steering committee. She's doing brilliant work with our social media and many other things. Now, I also have a podcast called Why Didn't Anyone Tell Me This? Thank you. So it's all about good health and happiness. So all the podcasts are, it really varies. We've had some on drumming. I do some drumming, and we have ones on chronic health conditions. We've got diabetes. We've got some on menopause, some on fertility. There are all different things, but mainly aimed at women. There's lots of things there for men as well. The one that was just released this week is about alcohol. And it's called Our Most Harmful Drug. And it's with a professor from the UK that's done a lot of work about alcohol. I drink, we all need a drink. It's nice to have a drink, but we've normalized that. But that's another story. Anyway, so the podcast is there, and you can access it on any podcast channel. So I do have some disclaimers. I do get paid by a number of companies to give talks, but nothing will interfere with what I'm going to say today. So this is our international reproductive health education collaboration. We have done a lot of work. We've made a wonderful fertility poster, and we have it in Greek. I'll show you that in a moment. We've done some work with teachers. We want to make sure that teachers really start teaching this in schools. Now, I know that in Cyprus, we've got a long way to go. So this afternoon, we're going to be talking about this. I'll talk a lot more, those that are staying for this afternoon, about the work that we're doing here. We have information leaflets on our website about all different aspects: endometriosis, PCOS, I'm going to talk about those in a moment, menstrual cycle, fertility, and we will be translating these now. So Christiana and others will help translate these into Greek very soon. So this is just a little background of where we are. And this is our menopause group. This is my wonderful team that I work with. One thing essential to the work that we do is we co-design it with the people that this is for. So we can sit in our offices and think that we know everything and we know how to teach different people different topics. But the only way we can really do that is ask those people, how do you want to learn about this? So that everything we do is with the group that we want to work with, mainly at the moment women, to ask them how they want this to do. So we do many things. So I'm going to talk more about that this afternoon. So what I think everyone, not just women, none of these issues are women's issues. These issues affect everybody. Everyone, what I think we need to teach, starting at schools, is puberty, the menstrual cycle, fertility, contraception, sexually transmitted infections, infertility, pregnancy, menopause. We've written andropause on there. For the men, there was a lot of discussion about that. It's not like our menopause, but we wanted to include them. Cancers that affect the reproductive system. I'm just about to do some podcasts for January about the female cancers, so ovarian cancer and breast cancer, etc. And then, where I'm going to finish my talk, well-being and lifestyle. This is really essential. This is the best preventative medicine. Do we teach any of this in school in Cyprus? No. Some of them. Yeah, in biology. In the UK, I've done a lot of work with the UK. In the UK, we teach people how not to get pregnant and how not to get a sexually transmitted infection. That's about it. Same in Cyprus. We don't teach them how to have a healthy pregnancy, or even when is the best time to have intercourse to get pregnant. And I've done a lot of work, you'll see, actually I'm going to show it this afternoon, but I've done a lot of work with school children to ask them, we've done surveys, we've even done one in Greece, to ask young people, how do they feel? Do they want to learn about this? They all want to learn about this. And young people want to have a family, and it's already in their mind. We asked them, do you want children in the future? Most of them said, vast majority said yes. How many children do you want? We want 2 to 3 children. So we need to get this started in schools, but we also need to teach this age appropriate. So we need to teach this when women and men are trying to get pregnant. We need to teach them more about their fertility. When women get to, for me, I think the age of 40, we should be having more discussions about menopause. So the age appropriate for when you're going through this. So I'm going to just talk to you. I know we've got a really mixed audience today. I'm going to talk to you about a few things that I think, the tip of the iceberg of what I think everybody should understand about their reproductive health. So we're going to start with the menstrual cycle and with periods. So we do teach a bit about this in most schools that we've looked at globally. We do teach, this is the menstrual cycle, and there's these very powerful hormones. These reproductive hormones are very powerful. And the two that you've probably heard about are estrogen and progesterone. Estrogen's always, everyone's always, and when we come to the menopause, it's really important. So estrogen and progesterone, but all of these hormones, one of my friends she's a dancer. She describes this like a dance. These hormones are dancing, but they're dancing around our body from puberty to menopause all the time. And they are very powerful, and they affect us physically and psychologically. So I'm going to talk a little bit about premenstrual syndrome in a minute, but lots of women can have a negative effect of these hormones within their body. So they control two main things that happen during our menstrual cycle. Ovulation is when we release the egg, and that's the fertile window. So it's about 6 days every month when we can become pregnant. People have said, oh, you don't want to teach that to young people because they might think, oh, well, there's just those 6 days. Outside those 6 days, we can have unprotected sex and not get pregnant. I think we need to give young people more credit than this. I think we need to teach them the proper information and let them be sensible about this. So I think it's really essential to teach them the real science. So the level of these hormones vary throughout the cycle. And as I said, they can have a positive or negative effect on our physical and mental health. So I'm not going to drown you with papers, but I've done a lot of research on all of these. I'll mention some of them later. So one of the top paper, actually, all of my papers are open access, so you can get access to them. But one of the things we did years ago was that we looked at some big data from people using an app that measured their menstrual cycle, monitored their menstrual cycle. And you were probably taught that we have a 28-day menstrual cycle. And our study showed that actually only 13% of women have a 28-day cycle. That was in quite a big data set. And we vary around that. So one thing in schools is that we're sometimes very prescriptive and say, okay, you have a 28-day cycle and your egg will be released on day 14. And women are not an algorithm. We're all very varied. So it's really important to teach the correct information. It's around about 28 days, but it could be 25 days. It could be 32 days. We are all individual. So a big message today, every woman here, we are an individual. We're not an algorithm. We're not something from a textbook. We're all very different. So we need to find out what's right for us. So that's a little bit about the menstrual cycle. And day 14, they always put day 14 in the textbooks, but it's normally actually around day 15 or 16, but really varies with every woman and every cycle. That's the time when we should be telling people if when they want to get pregnant, that's the time they need to have intercourse. We know in the fertility clinic, some people come and they're not doing it right. How would they know? How would they know when they were supposed to do it?
This is taught, I can assure you.
Yeah.
This is taken care of.
In the UK,
it's the fact that not all women have a 28.
Oh, they teach this in Cyprus.
Yeah.
Fantastic. In England, they don't. They say 28-day cycle. So there's still a lot to. We're looking globally at what's being taught now. That's one of the projects we're doing. So I, like Christina knows, anyone that follows me on social media, they know. In England, our rivers and sea is very cold. So I do something we call it cold water swimming because it's cold. But it's very invigorating. And lots of women love it. We love this lovely effect. It's really resets our mind. So these are some pictures of me swimming. But they illustrate these powerful hormones because they can make you feel like you're in a turbulent wave, in a storm of a wave, but they can also make you feel very calm. And I'm going to come back to the calm because post-menopause, this is how many women are telling me they're feeling when these hormones that we saw oscillating every day during our menstrual cycle, they have an effect on us. When you're postmenopause and those hormones have calmed down, we can be zen. We can be really, really zen. On my podcast, I've had two brilliant women who are endocrinologists, who are people that study hormones. Anise Mukherjee and Susan Davis, they're really world experts, and they talk about our hormones in those podcasts. So a little bit about the menstrual cycle. So premenstrual syndrome, about 90% of women experience some form, but only in about 20 to 40% is it severe enough that it's actually diagnosed as a medical condition. But it's that feeling about a week before your period is actually going to happen that women feel the lowest. They feel anger, they feel physically drained and not energetic. There's so many effects. I have done a number of studies with asking women how they're feeling about their periods. I did one with 15-year-old schoolgirls, which was enlightening. And I did one with all the ages up till then, and one with perimenopausal women. Do you think any of the women said they loved having a period? No, no, they didn't. We don't love having a period, and it is tough, but we need to talk about it. We need to talk about what they are. We need to talk about those women that are having very difficult, very painful, or very heavy, or very long periods. We need to talk about this. We need to talk about it in the workplace, and we need to talk about it at home, because if we have something like PMS or premenstrual tension, it can even happen 2 weeks before your period is due. So that's half the month. And there's the physical symptoms and the emotional symptoms, mood swings, anger, aggression, depression. I'm not going to read them all out, it's too depressing. But we need to understand. So if you're the husband in the house, when your wife has got PMS, it's a tough time. Yes. Oh, we're having flashbacks, I can see.
Got 2 cups.
Yeah, women throw things. Women have murdered their husbands as well and got away with it. I won't go there. But we just need to understand these are normal biological functions. We need to embrace them and understand how they're affecting us. And there's 5% of females have something called PMDD, where it's really, really severe. It really affects their life really terribly. I'm going to talk about 2 conditions that we never talk about, and they're 1 in 10 women. And we are school children. This is the most depressing result I got from my research with the school kids. We asked them, did you learn a whole list of reproductive health conditions? Did you hear about these, or did you learn about them in school? 2% of UK kids had learnt about endometriosis and the next one, PCOS, in school. Wow, both affect 1 in 10 women. So when I've got a group of 200 school kids in front of me, half of them are women, there's going to be at least 10 women in there, girls, who are going to have these conditions, and they know nothing about them. So what happens? They suffer for years before they're diagnosed. Because at 15, 16, if you've got pain from endometriosis and your friends are all fine with their periods, you think there's something, oh, it's me, I'm not being strong enough. I've got to be a woman, I've got to bear this. We don't have to bear it. We've got to educate them and understand. And when I give this talk in school, I have a row of girls afterwards coming to ask me more. Oh, I think I've got that. Yeah, I think I have got that. So 1 in 10, it's when the tissue from the womb, or tissue like the tissue from the womb, is outside of the womb. So a period's bad enough, but when you've got tissue that's now come outside of the womb, when they have a period, it can cause a lot of pain. And what's more problem, it causes scarring. So one of my best friends, she's in her 50s, she still has huge pain from her endometriosis. And it now is not related to her cycle anymore. She can have it any day at all. It's heartbreaking. So many events we organise and she just can't come. And it's so sad to have seen someone for 30 odd years have that experience. So we need to make people understand about this. And we need to make them understand about polycystic ovary syndrome. And we need to understand how this can affect fertility as well. Now, PCOS, they want to rename it because it's actually a metabolic disease. It's something that's not just about fertility. We call it, it's got ovary in the title, so you think it's just about fertility. But it's a more complex condition that has many symptoms, as you see there. So this is, in the middle is, when I go to the schools, I ask the schoolgirls with an anonymous survey to tell me, do you have any issues with your periods? And this is very typical from their replies. So these are 15-year-old girls, a lot of pain, a bit of pain. Pain to the point I used to collapse. Heavy, usually lasts 10 days, irregular, and so much pain. Painful first 2 days, back cramps, bowel problems, back pain. This is not edited. This is just one page from 15-year-old girls, and this broke my heart. So this is what I did a lot, asking women, how do they feel about their period, and try to understand. In the UK, the most I've ever heard is that girls have a lesson when they're about 7 about their periods, and one when they're about 11. And that is it. 2 school lessons in their whole life. Is that enough? And then, even in the UK, I'm sure it's common here, the boys are in another room. They don't even learn it. And you know what? Those boys are going to grow up to be husbands, fathers, work colleagues, and they need to understand what the women in their lives are going through. So I'm very fanatical about that. So let's move on to fertility. Here's our fertility poster in Greek. Fantastic. All of these are freely available on our website. Anyone can download this and use it however they want to use it. So males, we haven't let the males off. We talk about females losing our fertility. I think probably everyone knows that we have a biological clock, and that when we're post-menopause, we are not fertile anymore. We cannot have babies. So males are also affected. When I go to schools and often at events, I did this last Saturday. I said, what older men can you think of that have fathered children? Can you think of some now? Older celebrity men, famous men who have fathered children. Shout some out. Robert De Niro. Yeah, there's a lot of actors. Charlie Chaplin. Oh yes. Alec Baldwin, and all the pop stars, Mick Jagger, Rod Stewart, all these. They're all at it. Oh, 70s and 80s, they're fathering children. Do you know what? Their common thing is their partner is not the same age as them. She's very young and fertile. So, but men's sperm does go down. It's not as healthy, so they have fewer sperm. There's an increased risk of miscarriage. We blame the women for everything. It's the men too. And it can take longer to get their partner pregnant. So it's important. All of these slides you'll see are the ones we want the teachers to use in schools. These are all from our international group that we've worked on for many years. We want them to teach this. But this is depressing for everyone in this room, that our fertility goes down. This is a picture from my book, actually, and the rate of miscarriage goes up with age. So we talk about age 35. We don't wake up at age 35 and we are losing our fertility. It's a gradual process. But by age 35, for most women, trying to get pregnant is going to be tricky. So what's really important is that women are born with all the eggs we are going to have. And some people really aren't aware of that. We have a lot of eggs when we're a baby. We have 1 to 2 million potential eggs. By the time we've got to puberty, most of those have died. They've been reabsorbed by the body. So we only have a few 100,000 left. You think, that's enough. I only need 1 or 2. Okay, but every time we have a menstrual cycle, we ovulate 1, but up to 1,000. So normally about 700-800 eggs every month will just be reabsorbed by the body. They just, which is really depressing. It's a really bad design. We are a very bad design. By menopause, they've all gone. So these guys produce new sperm all the time, till the day they die. And our eggs are going off from before we're actually even born. And the quality also goes down. We have these chromosomes in the egg, and they become very fragile. So this increases our risk of miscarriage, of having a chromosomally atypical child, and decreases our chance of getting pregnant. Women don't want to hear this, especially women in their 30s, but we have to do it. We have to teach them this, and we need to teach this in schools. So we've done some studies asking women, we asked them lots of things. This was one of the first studies we did. What age do you want to have children? Now, I wanted to have children at 30. This study was done a few years ago. I thought they were going to say older, but most of them said, actually, they want to have children around the age of 30. But they're developing our career, finances, lots of things we want to do before we do that. Now, this is some really important data. You may have heard that the global fertility rate is decreasing. We're having less children and we're leaving it later. And globally, this is actually a problem because we should be having, in every culture, we should be having 2.2 children per woman to keep the population going. It's the replacement fertility rate. But we have two problems. The first is that women now are having children much later. So you can see here the black diamond is 1980, and this is the mean age at which they had children. The white diamond is 2000, and the blue bars are 2022. And Cyprus isn't on it, sorry, but Greece is on it. But Greece is really high. I think it's around about 32. Age 32. And remember, our fertility is starting to become important in our 30s. Age 32, if you want 2 or 3 children, which people do, this is cutting it really fine. It's gone up for men, but as we said, for men, it's not quite so important. So if we look for Cyprus, this is the fertility rate is the average number of children a woman has in that population. It's 1.4. How many children do we all want? Most people want 2 to 3 children, yeah? We want 2 to 3 children. So people are not having the desired family size, partly because they're leaving it so late. So education is really key. If you want a family, you must not leave this till you're 40, because then it's not going to happen. And this bar here, sorry, it hasn't got Greece on, or Cyprus, but this is the percentage of women remaining permanently childless. And look, in Japan and Spain, look, Japan is coming up to 30% of women in that country do not have children. Some of them, it will be by choice, for sure. But not for, I don't even think half of this is by choice. I think most of this is not by choice. So we've got to educate. So I just want to say something also about egg freezing. You'll hear a lot about egg freezing. At 30, my partner wasn't ready to have children, and we actually split. And then I went through years of fertility treatment to have my children. So I know what this is like, and that wasn't my plan. At 30, I would definitely have frozen my eggs, but I say I wouldn't have made it plan A. Plan A would have been to get pregnant naturally at 30, but if your partner's not ready or you don't have a partner, plan B is freezing eggs is a good option. So with freezing eggs, because of this female decline, we can, through the fertility clinic, we can take the eggs and suspend them in animation so they stay the age that they were when you froze them. And I always advise people to do this as close to age 30 as they can. But even in the UK, the average age people freeze their eggs is about 37, which is not good, because it means a lot of them are over 37. And we really need to do it younger. But the trouble is, we must know there's no guarantee that this procedure will definitely work. And we need to let people know that. So it's complex, but we want them to teach this in schools. I meant to ask actually about what everyone thought about AMH testing. So the comment on the right is from our international teaching guide, is that, so it's not just my view, there are no tests at the moment that can predict your fertility. There's tests that can show there's something wrong. Maybe your fallopian tubes are blocked or your hormones are not working. But normally we would say, try to get pregnant. Most people will get pregnant within a year. And then if you don't get pregnant, then you can go for tests. But there are claims that this particular test, it's called AMH testing, or it's often marketed as a fertility test. You can even buy this on Amazon. But in the UK, it's really being marketed, especially to women in their 20s, that they can have this hormone checked and it will tell them their fertility. And unfortunately, that is not correct. And I've interviewed Tessa Kopp. She works in Australia. She's one of the world leaders doing research on this. She's been on my podcast, and we said, is this empowering? Is this sort of health check, including this test, is it empowering or exploiting women? And she made it very clear she did not think a 25-year-old woman should have their AMH tested. It leads to too much misinformation. So you can get pregnant if the result's poor, and you can be infertile if the result's good. So if you do a test, you need the test to have a result that you act on. Now, if the result's good or poor and it doesn't mean anything, it's not helpful at all. It leads to a lot of misinformation. Either way, what they normally say to people, oh, freeze your eggs or go through IVF. And I know that in Greece, they have been offering this, and we can discuss it later, but it's complex. Now, just to finish off the fertility part before we go to menopause. So, possible causes of female infertility. We want this taught in schools. There are many reasons that I won't go through all of them. We've got to really be aware about our lifestyle, about nutrition and smoking and vaping and alcohol and all of those other things. But there are tests that we can do. About 40% of infertility is the female, 40% the male, and then 20% is what we call unexplained, which is what I had. Male infertility, various things. A lot of men now, all these bodybuilders, these anabolic drugs and steroids, it really worries me because this really affects their fertility, and we have to be careful about that. So here we are, the menopause, woohoo! So I'm not going to tell you too much about what we've been doing with our InTune project, but just very quickly, we have 2 educational times we think we should teach everybody about this. One is called Be Prepared for Menopause, and I'm going to go through it more this afternoon, but we at the moment, it's a 2-hour session. We're going to offer it online. I've done a lot face-to-face, where we teach everybody about the basics of menopause. So what you're going to learn about in a minute. That's where we want to do that. And we've designed a really lovely program to do that. And it's been really great to start teaching that. But when women are in it, when they have the symptoms, we want them to come back to, I don't know, you probably have this here, when you're pregnant, do you have classes that you can go to and you learn about, but you're pregnant then, you've got to learn about the hemorrhoids and the trapped nerves and the wind and the indigestion and all this, but you need to be in it to do it. So this is what we want to do with Be Supported Through Menopause. When you're in you're having the symptoms, you come, you talk to other women who are experiencing it, and you really embrace it. A little bit more about hormones. So this is very simplified, but remember at the beginning I said estrogen and progesterone. I just wanted to show in the middle, in the fertile years, it wasn't my diagram, but in the fertile years, the hormones are going up and down for sure. But so this is just showing a straight line, but they go up and down. But I just want to show you puberty and the perimenopause. So the perimenopause are when these hormones and puberty, they've gone a bit crazy. They're going up and down. So I always say that the perimenopause, so this is before a woman's periods stop, when she's having most of the symptoms, is like puberty in reverse. So in puberty, these hormones, powerful hormones, are cycling up to then lead us to our menstrual cycle. And in menopause, they're cycling down. And post-menopause, they're calm. They're that calm sea that we saw, which is wonderful. So I love this diagram. So this is the pre-menopause. This is our normal menstrual cycle. One of the women I interviewed for my book said that the perimenopause is like you've given Emily, age 5, some crayons and told her to go mad. And she's gone mad. Look, she's just created this madness of these hormones. So these hormones, I said, they're powerful. And in perimenopause, nothing's predictable. Your period's not predictable. And when you wake up in the morning, what level of these hormones you have in your body, you have no idea. So for your fertile years, you knew, hopefully you're tracking your cycle, you know, okay, in the beginning of my cycle, I'm going to feel like this, in the middle, I'm going to feel like this, and just before my period, I'm going to feel like this, but it's regular, and you know, and you can work with it, be in tune with it. Perimenopause, no. Oh, it's gone crazy. So is your estrogen high today? Is it low? Is your progesterone high, low? What's the ratio? What's going on? So it's a really tricky time. So we've done a lot of surveys with women. I wanted to hear from women. What do they feel about this? So I've done a lot of different surveys with young women and older women and different types. I've done focus groups. I've done interviews. I've spent the last 10 years talking to women about their menopause. So this was a real shock. We asked women, a big survey, 3,500 women. We asked them what were their top symptoms. We actually gave them a list of 52 potential symptoms. And when we did this, the clinicians I work with said hot flushes. We all know about hot flushes. Okay, hot flushes, night sweats, that's the top symptom. I said, let's ask them. So we asked them mood swings, brain fog, fatigue, period problems, anxiety, irritability. Night sweats is number 10. Hot flushes was number 20. And the clinician said, well, that's really strange. That's not what we thought. Okay, but did you actually ask anybody before? Oh, no, we didn't. Okay, let's ask them. So 5 years ago, no one talked about the psychological menopause symptoms. We just didn't talk about it. And now everyone's talking about it, and I'm really pleased. And I'm not going to say too much about it. I'll leave this to the next speakers. So this was just a bit of fun. I asked women in my surveys, how do they feel about stopping having a period? Because men kept telling me that women like having a period. So I asked them, are you happy? They're happy to stop having a period. Hooray! Right, and I just want to be controversial. I absolutely, 80% of women have severe perimenopausal symptoms, as I have heard from all the discussions I've done. I'm not undermining that, but I just want to be controversial because I know the other speakers are going to cover this. But 20% of women don't have symptoms. So again, understanding we're all individual. These are some quotes from the women from my book. I sailed through it. I was lucky. I was healthy. It didn't cause me any problems. My body sailed through it. I don't think I had one. Okay, so we must understand that we're all different, but you'll hear more about perimenopause in a minute. So my last things I want to say is that postmenopause can be our most joyful years. Yes, but we've just never talked about it. And yes, we might go through we probably are going to go through a difficult perimenopause to get there. But we need to let women know that there is light at the end of this tunnel, because at the moment we are medicalising women's health and saying there's something wrong with all these women, they're all going to fall apart and go through this terrible perimenopause and blah, blah, blah. Okay, there is light at the end of the tunnel. So we have no more cycling hormones, no more menstrual cycle, no more period, no more PMS, no more contraception. And in many cultures, they celebrate this time of a woman's life where she is an elder. She is a respected member of the community. She may have had children, she may not have, but she is now a wise woman. And wise men as well, but we're talking about women today, okay? You're wise men. Another day we'll talk about. In traditional Chinese medicine, they call this the second spring. In this one in the middle, I can't pronounce it, but this is the Maori language, have a woman of high rank who possesses knowledge, celebrating us. And in Japanese, it's Gynaecological, which means rebirth, renewal, wisdom. We need to do this. We need to do it. So back in 2019, they had a whole week in UK TV talking about menopause. And they asked me, can I get some women who think positively about menopause? And they did a little session for the TV. And these are some women who are inspiring role models who I've had on my podcast. And then the joyful years, for sure. So just one more thing, a couple of things I want to say. The trouble is, especially in the UK, because of social media, it's a wild west of menopause. Companies have realized that women of our age, we might have some money, we have some time, what can we sell them? Let's sell them something. So they are marketing that. There's one very well-known doctor in the UK that it's sick. We're all sick. It's a hormone deficiency, and we're going to become a dried-up old woman unless we take HRT. HRT absolutely has a place. We're going to hear about that. I've never taken HRT, just my choice. I didn't want to. I was okay. I feel fantastic. Women on HRT feel fantastic. Basically, women over 50, postmenopause women feel fantastic. The women in my book, a third of them were on HRT and the 2/3 weren't. They all felt fantastic. I've done a podcast with Amanda Thebe, who's a very big influencer in the US, navigating the wild west of menopause. In the UK, they're even selling women menopause chocolate. I'm seriously. It has one almond in, apparently. One almond. Almonds can help, but one almond. Menopause tea. We have menopause clothes. I don't know how much of this has got through to Cyprus. Yeah?
In England.
Yeah, in England. Oh, we are nuts, honestly. Menopause, the supplements, I'm going to talk a little bit about the supplements this afternoon. I've done a lot of work about menopause, and we're doing work on fertility supplements. Okay, women wasting hundreds of pounds a month on supplements. In my view, at this moment, we have no evidence that any of them are going to help. If you have something wrong, just go and see your doctor. If you're not feeling right or you're worried about a deficiency of something in your diet, see your doctor. Do not take the supplements, please. They are really, really a waste of money. And then Gwyneth Paltrow, anyway, just please ignore Gwyneth Paltrow. Just to finish, what I really want people to embrace is our pillars of health, our nutrition. And listen, you're here. We always talk about the Mediterranean diet. You're here and living the Mediterranean diet. Exercise. This is my swimming. Look at us mad women swimming. Sleep. So in 2026, I want to make all of this sexy. I want to make going to sleep early, going to bed by 10:30 sexy. Mental health. We need to make relaxation. We talked about breathing earlier, wherever it was going. Relaxing, calming our crazy brains. I said at the beginning, we're not living the lives our mothers and grandmothers led, who weren't doing all the crazy things, coming out on a Saturday and listening to a talk, okay? We have got to calm ourselves. We've got to relax. We've got to have walks in nature. However we want to relax. We all want to relax in different ways. And our friendships and community. Women need to find their tribe. They need to find other women who are similar to them, who they can spend quality time with. And this is my wheel of health and happiness from my book. So our creativity, our hobbies, traveling, relaxation, quality time alone, time in nature, sense of purpose. We do need a sense of purpose, not just our family. Sex and love. Well, I won't go into that today, but I do a lot about sex and love as well. And then those are all our pillars of health. So the social media, we have to be careful. There's something called infotainment. Okay, and these people, Gillian Anderson, who I love her, she's a brilliant actress. She sells this drink that she says will make you sexy. It doesn't make you sexy, okay? So we've done some work with Christiana. We've done some work looking at how social media does. We'd be very careful about social media. If someone's selling you something, just be careful, okay? We can all get sucked in we're scrolling at 1 o'clock at night when we shouldn't be and think, oh, I'll just do this supplement. Look at all these women saying it makes them look fantastic. So we need to listen to women. Every woman has a voice. We need to listen to them. How is their life? How can we improve their quality of life? And we need to empower women through education. So that's some of my wonderful team. So I do a bit on social media. If you want to follow me, it's at Prof. Joyce Harper. Thank you.
Thank you, Joyce. I think we'll all agree that was an amazing talk. Now I'm excited to introduce our very own Dr. Mantrali, Effie Mantrali, consultant obstetrician, gynaecologist, and specializing in reproductive endocrinology, fertility, and women's health. Dr. Mantrali will be speaking about the reproductive ends of women.
Thank you all for coming. That's going to be a tough act to follow, Joyce, but I will try. So, I am going to talk about the reproductive ends of women. Let's get the presentation up. Thank you all for coming on a Saturday. I know mid-December, getting ready for Christmas, can't be an easy time to leave your families behind, so very appreciative for sure. So, the reproductive ends of women. This is our female fertility timeline, right? So, like Joyce said, right at one end of the spectrum, we have ages 18 to 24, where we are told is the best time to procreate because our fertility is at an all-time high. And that's what we should all be doing, right? Very, very personal decision, so I don't have any opinions on that. I'm going to focus on the latter part, which is the other end of the spectrum and looking at ages sort of after 36, 37, where things are very, very different. So this is an outline of my presentation. I'm going to talk about the stages of menopause. I'm going to talk about the potential symptoms, although very individual stories, as we know, potential treatment options, and of course, a little bit about bone health, because that's also not talked about very much, and I think that's very important. So this is what a woman's journey to menopause could potentially look like. I'm going to break down some terms because it's important to know when we're using the language what it means. Premenopause is essentially before hormonal changes start. Perimenopause is where we are having these extreme fluctuations, and this usually occurs somewhere between 40 and 50, and it can last for several years. So this is what the word perimenopause means. Once menopause is established, it's actually a retrospective diagnosis. We look back and we say, oh, a woman has now not had a period for 12 months continuously. She is menopausal. And postmenopause is once a whole year has passed where we have established that we are now menopausal and we are in the post-menopause phase. So defining things is very important because it will make a difference how we treat. When we are talking about medical or surgically induced menopause, a whole different ballgame. That is very abrupt. That comes on very suddenly. For example, in women who have had to receive chemotherapy earlier on in life, and they will have entirely different symptoms. And again, the treatment is going to be very different. It is not the same as a woman going through the natural journey of getting to the stage of menopause. And we do treat these women differently. What about timings? So usually the median age we look at is about the age of 51. This is purely from studies. This is what the evidence says. Approximately age of 51. It will be somewhere between the ages of 45 and 55. 10% of women are going to become menopausal between the ages of 40 and 50, about 1 to 2% less than the age of 40, and 0.1% under the age of 30. Of note, ethnicity makes a difference. So women who are of Indian background, they will actually go through the menopause 5 years earlier. And women who are of Afro-Caribbean background will actually go through the menopause 1 to 2 years earlier. So really these averages are very specific in terms of ethnicity, and we haven't looked at other groups. So these are all symptoms. And as you can see, it's very crazy. It resembles the perimenopause, doesn't it, this slide? So before I talk about all the symptoms, and there are loads, like, there are potentially, to our knowledge, 50 symptoms, possibly more. There is one crucial question that when a woman enters, doctor's room, we have to ask ourselves, when she says, doctor, I think I am menopausal, I'm going through the menopause, I'm in perimenopause, they use all these words, is it the correct diagnosis? Because we can get it wrong. It can be that there's something else going on. So we do need to rule out thyroid disease, inflammatory conditions, autoimmune conditions, anemia, and there is no blood test to make a diagnosis for menopause. When it comes to the perimenopause or menopause, we do actually have to make a clinical diagnosis. But we first have to rule out if there are any medical conditions because there's an overlap of symptoms. And that's where some tests do become necessary. So that's the right thing that we should be doing. So in clinic, women come and they say, what are the symptoms? Please tell me what the symptoms are. I want to look out for them. There's many. Look, Joyce has already spoken about them. There's so many symptoms. So what involves a little bit of everything. So all of these that you see there are on, and we talk about them, we make little notes, and we come up with where the problem lies, essentially. Some are more troublesome, some are less. So the next question is, so why is this happening? This estrogen hormone that we hear everybody talking about, dreaded estrogen hormone. Actually, yes, The decline in the production of estrogen is a problem. However, really, the manifestation of symptoms is a direct result of the metabolic changes that are associated with the menopause. And these changes are in our lipids and lipoproteins, in body fat distribution, in blood pressure, in glucose and insulin metabolism, in bone turnover, in coagulation, and the clotting system in our body. It goes mad. Every single system in our body has basically gone mad because our ovary has suddenly decided that it just doesn't want to produce the same amount of hormone at the various stages of our cycle every day. And that has an impact on every single organ at a cellular level. And of course, every woman will experience it very differently. In some women, the metabolic side in terms of how we deal with body fat will be very different, whereas in others, it's the way our brain works. So we have to look a little bit at what we can do about it. And I keep going back to individualized management. So this is a slide on treatment options. I have put lifestyle modifications on there because I am a big believer. I'm not going to spend a huge amount of time talking about it because others will. But I do a holistic approach. And I really do believe that to some extent, as clinicians, we do need to talk about lifestyle modifications. We may not be able to offer everything in one appointment, but we may be able to refer. We may be able to advise. Non-hormonal treatment options, very legit and very much something that qualifies as a treatment option. And of course, the dreaded hormonal treatment, which I'm going to spend a bit of time on. So, lifestyle modifications. Nutrition, movement, sleep, Joyce has mentioned this, reducing stress, stopping smoking, reducing or stopping even the alcohol intake, and of course, a supportive environment at home. I am a big believer that they do go a long way. They make a very big difference, but I will let others speak about this later. Now, when it comes to non-hormonal treatment, which very many women come into clinic and they do ask about, what are these? One option that we do have available to us, and we do have this available in Cyprus as well, is local vaginal estrogen. And this is specifically for the treatment of the genitourinary symptoms. So the symptoms that come either during the menopause, perimenopause, or they come many years after the menopause has been established. So these symptoms are vaginal dryness, incontinence, pain during sexual intercourse, developing a higher number of urinary tract infections, possibly also pelvic floor prolapses. And in the women that we see, there is a small degree of pelvic floor prolapse. Actually, we find that vaginal estrogen could help. And those are the cases where they don't qualify for surgery anyway. But we have to do something. Okay, now the most important thing to say here is vaginal estrogen is not considered hormone replacement therapy, and there is very little to no systemic absorption. This is not the same as giving estrogen in the form of any systemic tablet, because it does not have an effect anywhere else other than the genitourinary system. The other thing that is usually the foundation of many of these supplements that do exist out there, like Joyce has said, is what we call phytoestrogens. And what are phytoestrogens? Phytoestrogens essentially are plant-based compounds, and they exist in many things that we eat. So for example, isoflavones that exist in soy products, or red clover. We've got lignans that exist in flaxseed that we want to breakfast in the mornings. So herbs, black cohosh, wild yam, potatoes, dong quai, hops. For some women, this may make a difference. Balancing their diet may make a difference. So we do have to say that they are available, and we do have to say that there isn't enough evidence on supplements. We have to give it time to come out to see which supplements do make a difference and how much of a difference they make. When women ask me about supplements because they really, really don't want to take HRT, I always say, look, there's no harm trying something. But if you do have a balanced diet and you are doing all your lifestyle factors, then the chances of a single supplement making this big difference is going to be limited. But give it a go. And a lot of them come back and they say, yeah, you were right. It didn't make much of a difference. Or some will say, yes, I think it has gone to some extent. It made a little bit of a difference. And that's fine. And that's great. And I'd be happy that I've helped them in some way. So the next slide is on HRT. And I am going to spend a little bit of time on this because I think maybe many of you, that's why you're here, to decide if it's a yes or a no. There is no answer to that, okay? That's the first thing to say. So the first thing that I want to say is that HRT is the most effective option for symptoms in a woman who has no medical contraindication and wants to take it. If a woman wants to take HRT and there is no reason to say you shouldn't be taking it because it will cause harm, then that's a good woman to take HRT, okay? It does have proven benefits because it is the type of medication that has been researched a lot when it comes to care of the woman in her postmenopausal years. And I will talk a little bit about where that research initially started from. And it has had a proven benefit on bone health, and more evidence is coming through about other potential health benefits. However, big however, this is very much an individual assessment that needs to be made by the woman's doctor based on every woman's risk factors versus what benefits she would have. In cases of premature ovarian insufficiency, where we really do need to give hormones because the ovaries are not producing the hormones at a much younger age, it is a completely different conversation to the conversation that you're having with a woman who is slowly following a very natural path to becoming eventually coming into her menopause years. So two very different conversations that we are having when it comes to hormone replacement therapy. So very, very much individual assessment. What routes do we have? The most common route, and the one that has been around for a very long time, is tablets, oral. However, more recently, we know that there have been transdermal routes available. So we have patches, we have gels, we have sprays. Some of these things don't exist in Cyprus yet, but they have existed for many years in other countries, and they are suitable for some women. We also have subcutaneous implants. I know they're very popular in South America, subcutaneous implants, vaginal creams, pessaries, gels, rings, and of course, intrauterine systems, what we commonly know as the Mirena coil. These are all legitimate routes and ways of delivering hormones to the body. What do we choose? How do we choose? Do we want to have a period or do we not want to have a period? I think the consensus is we don't really like having periods, but we may not have a choice. If we're going to have to give HRT, we may not have a choice. So two types of HRT. Sequential is the type of HRT where we combine daily estrogen with progesterone for 10 to 14 days of a 28-day cycle, if we need to give it a number. And this is designed for women who still are getting periods. Continuous combined HRT is a daily regimen where we give estrogen with progesterone, and we're taking them together every day for women who have been in established, so they are postmenopausal, so we can say they have not had a period for 12 months. So they are both legitimate and suitable forms of HRT, but just for different types of women. We also have estrogen-only HRT. This is suitable for women who do not have a womb, so who have had a hysterectomy and they do not have a womb or cervix. In women who have either had a subtotal hysterectomy or they have had a hysterectomy because they have had that for treatment of endometriosis, estrogen-only HRT is not suitable. Then we have this big conversation about bioidentical HRT. There is no evidence that bioidentical HRT exists. It's a marketing term, okay? There's no evidence, and it is not safer, and it is not better. Our body is producing these hormones. By giving hormones that somebody says look more similar to what your body used to be producing doesn't make them safe. It is a marketing term. Every single hormone is produced in the lab in exactly the same way, with the exception of Premarin. And just because it's a hormone doesn't make it safe. Okay, they are still drugs. Now, having said that, since November 2025, Premarin's supplier has now pulled the brand, so it's debranded it, which makes it cheaper, which is great. So it now is just known as conjugated estrogen tablets. And this means that it is now more accessible to women. And for the women that need estrogen, this is a good treatment to give. So we do need to talk about the cases where we shouldn't be giving HRT to women, where somebody walks into the clinic and you say, I really want you to give me HRT. And as a doctor, you need to turn around and say, I'm sorry, but I don't think that's a good idea. There are contraindications. So this is a conversation a little bit about the risks with numbers and a little bit about why, on an individual level, we shouldn't be giving HRT. Stroke and thrombosis. This risk in a low-risk woman has a low absolute risk. What does that mean? If I was to take a woman who has a background risk of having a clot, the risk to that woman is 6 in 10,000 per year. And the number goes up to 12 in 10,000 per year if I was to give her HRT. So that means that the absolute increase in risk is actually low. That's why we say in a woman who does not have risk factors that increase her risk already, her risk of stroke or thrombosis is low. This is the evidence for oral estrogens. In transdermal preparations or subcutaneous preparations or intrauterine delivery systems or vaginal preparations, there is no evidence, but the risk is considered to be even lower because the absorption is less. The other question is regarding cancer. So we're going to talk about endometrial cancer, so cancer of the lining of the womb, and cancer of the breast. So of course, if we were to deliver unopposed estrogen, so we started giving a woman with a womb and therefore the lining of the womb estrogen without balancing it out with progesterone, then yes, we are increasing the risk of that woman in developing hyperplasia of the lining of the womb, thickening the lining of the womb. Why? Because this is what estrogen does. This is what we want it to do. Okay? When we looked at the menstrual cycle earlier, we saw that when estrogen goes up, after it comes down, we bleed. Because what does estrogen do? It increases the thickness of the lining of the womb. So in 25% of women who remain with a thickened lining of the womb, we will see cancer because there is a risk if that thickness remains there. How do we solve this problem? We give them progesterone because what does progesterone do? It thins the lining of the womb. So there is a way around it. This is not the case for women who already have an increased risk or they have genetic factors or hereditary factors that will increase their risk. Different conversation because over there you know that you already have a much higher risk. Therefore, by adding estrogen, you may potentially be switching on a mechanism. The same with breast cancer. The absolute risk of a woman who is considered to have no additional risk factors in developing breast cancer and has a background risk is for an extra 5 in 1,000 women per year if you are receiving HRT. This is not every 5 years, sorry. So this is not the same as a woman who either has had a personal history of breast cancer, has a strong family history of breast cancer, or has a genetic component that may at any one point in life increase that risk of her developing breast cancer. So again, in a low-risk population, very low, in a very low risk. There's big conversation about heart disease. The evidence, very little. It's a very recent conversation about whether taking estrogen is going to protect women from developing heart disease. What we do know is, at the onset of symptoms or within a few years of the symptoms starting and under the age of 60, there is some benefit. That is all we know. The jury's out. We don't know what that benefit is. And certainly beyond the age of 60, if you were to be commencing HRT, we don't think that it has any effect on the heart. So there is this new class of drugs that's coming out. And I don't know how quickly it's going to get to Europe and then Cyprus, because we do have, a slower rate of getting things done here. However, the reason they've developed it is for women who cannot take HRT. right? It's developed for women where the doctor will turn around and say, I'm so sorry, I know this potentially could solve a number of the symptoms that you're having. However, I can't give it to you because I'm putting you at risk. It's a drug that targets the temperature control of the brain. So it is non-hormonal. And this is very specific to hot flushes. So if the issue is hot flushes, the FDA has now approved this drug and it's on the market, and it is very specific to that symptom. And because traditionally we were a big believer as clinicians, and Joyce quite rightly said doctors are still way behind to their patients because they still think that 75% of patients will complain about hot flushes. That's why it was probably developed. If the problem is hot flushes and you don't want to take hormones, this drug, branded as Veoza, may be suitable. As with any drug, we have to wait for the data to come out. We have to get it tried and tested. So I can't really vouch for it because there isn't very much out there and it's still only available in the US anyway. So why did HRT get such bad rep? It got very bad rep at some point, like women were blaming their doctors. Doctors felt like they had basically signed their patient's death sentence. There was a study, there was a very important and very useful and powerful study back in 1991 that was led by the Women's Health Initiative. This was in the US. It was a really nice long-term landmark study that recruited 160,000 women. I mean, this is a very powerful number, right? And they focused on studying what was happening to these postmenopausal women when it came to their bone health, when it came to major diseases like heart disease and cancer. They, of course, did not believe that they would have negative results with HRT. They actually believed that they would prove that if we gave postmenopausal women estrogen, they would become much healthier and they would have less disease. It was 3 clinical trials, 1 observational study. And unfortunately, the initial interpretation of the results showed the opposite. It showed that if we give women estrogen and progesterone, we are going to increase their risk of heart disease, stroke, breast cancer, and dementia. And they published these results. And as you can imagine, what happened was this big shock to the population because a lot of women had been on HRT and they became very scared. So did many doctors. So we saw a very sudden and sharp decline in the women using HRT. Now, what later happened was they looked back and they reanalyzed the results and they realized that in older postmenopausal women, we conducted a study because they already have increased risk factors and we gave them something that increased their risk factors even more. However, when we analyzed the younger women under the age of 60 and whether HRT was beneficial or not, actually, women in early menopause who are experiencing symptoms will have relief to their symptoms. And overall, the benefit of HRT in the women who have symptoms, are low risk and want to take it was more than the risk. Of course, the very first results had a major impact, and it took us many, many years to restart the conversation that we are now talking about who is most suitable to take HRT. What the FDA has done and gone a little bit of a way to rectify the disaster that happened back then was that they recently lifted the black box warning. What was this? On every HRT product in the US, there was a big black box saying, this is very dangerous, please be careful if you take it. And they've lifted that black box after reassessing the evidence that was out there and saying that new evidence has now come to light and it no longer is as dangerous as initially thought. Now, the truth is, it has to be a decision between the clinician and the patient, whether a woman is suitable and is deemed safe to trial HRT. For some women, it will be, and they'll turn around and say, oh, doctor, you've saved my life. In others, they'll say, to be honest with you, it's done nothing, it's doing nothing. So we have to prepare women a little bit about what to expect. We need to manage expectations. When we talk about the temporary effects of what a woman might be experiencing when they first start HRT, we have to talk a little bit about headaches, about breast tenderness, about nausea, breakthrough bleeding. These are usually mild and they go away. We also have to tell women that if you have ongoing and continuous bleeding after your periods have stopped and it doesn't go away, you must come back and we have to investigate this further, because it may not be the HRT, or maybe, yes, the HRT has triggered something that we did not know about. So giving women the power of information so that they understand what is happening to their bodies, very important. And it goes back to what Joyce was saying. The other thing that we have got to pay a little bit of attention to, and I'm finding is actually more and more, is this progesterone sensitivity. So about 10% of women, you will give them progesterone to balance out the estrogen, but they are very sensitive to it. They will come back and they will tell you, oh my God, great when I'm on the estrogen, but what is happening on those progesterone days? This is awful. I'm sleeping all the time. I can't go to work. I am very, very swollen, severe breast tenderness. And that's where we need to adapt the dose, we need to change the preparations, and we need options to be able to do that, which we will talk about in the afternoon. So, common questions. Do I have to take it? No. The simple answer is no, you do not have to take HRT. Is it safe? We've talked about safety extensively, and I think it's a very individualized decision once we give the women the information, whether they would like to try, whether they think it is suitable for them, whether they want to stay away, and these are all very legitimate decisions, and it is okay to have them. How long does it usually take to work is a very common question I ask. As a minimum, and this is with many drugs really, 3 months before we start having any noticeable results. It varies from woman to woman. In some women, it takes a little bit longer. In some women, they'll come back and they'll say, oh, from the first day. I don't know how legit the first day is or the first month is, but it might be in combination with improving their lifestyle factors. It might be lots of other things that are also contributing to a positive experience. Now, usually women don't take it for their entire lives. We do wean them off at some point, but on average, we're seeing that they take it between 5 to 15 years, and then we start weaning it off slowly until they stop it. Because as with our graph previously, we see that estrogen eventually reaches a low stable line. And that's when you no longer are having the symptoms of this all over the place hormone picture in your body. So it's okay to stop. Sometimes symptoms may come back, so we change them to slightly different preparations. So if they were on tablet preparations, we may choose to change them to a transdermal preparation. And again, very, very individualized. So I'm going to talk a little bit about bone health, because this is actually what we need to be doing to look after women. They may not have symptoms, but if they have osteoporosis, they will break a bone and that will put them in hospital, and that will really, really impact the quality of their life. So even if they don't need to come and see a doctor because they haven't got any symptoms, we need to educate them about what to do to keep their bones healthy. So what is osteoporosis? Essentially, osteoporosis is a diagnosis made when a person's bone mineral density measurement falls below a certain threshold. And when the bone mass is lower than the average, but not as low as when it is osteoporosis, a person is said to be osteopenic. So 2 different definitions. And when we talk about these, these words are used very interchangeably, but it is important for women when they have tests to understand what their test report says. People with osteopenia do have a higher chance of fracturing a bone, breaking a bone, but not as high as osteoporosis. If we leave osteopenia and we don't treat it, it will turn into osteoporosis. And the most important thing is that osteoporosis doesn't actually have any symptoms. So the first time that a woman might find out she has osteoporosis, if she's had a very minor trauma, but she's had a very serious fracture. So this is often what we see. And that's why we need to come back and educate. So who is at risk? Any woman above the age of 65, any woman that's got a history of a fracture, especially as an adult, or a very strong family history of osteoporosis or adult fractures, particularly hip fractures in either parent. So knowing your family history, very, very important. Low body weight, so a BMI less than 22. Smokers, current smokers, smoking does actually put you at a higher risk of osteoporosis. Prolonged use of certain medication, which may be necessary, but we just need to be aware of them. Things like steroids, chemotherapy, anti-seizure medications, some types of birth control, in fact. So we need to be aware of the patient's history when we're talking about how high a risk they have in terms of developing osteoporosis. And as you can see, early menopause, the age of menopause, if you go through the menopause before the age of 45, you are at higher risk of developing osteoporosis sooner. Excess alcohol intake, and then chronic medical conditions that, of course, have to be managed, but we need to be aware of them. So things like malabsorption syndrome, where they're not absorbing enough from their diet, enough calcium, enough vitamin D. Inflammatory bowel disease, again, they're not absorbing enough because the bowel has a disease. Chronic liver conditions, kidney disease, and of course, gastric bypasses. So how can a woman find out if she has osteoporosis? They will say, oh, great, so you've just told me that I might be at risk. How do I know? So we have this lovely test called a DEXA scan. And a DEXA scan stands for bone densitometry. It's called dual energy X-ray absorptiometry. Very fancy word, just remember the word DEXA. That's what I do. And essentially, it looks at the bone density, and it gives you a number, and then it gives you a T-score, and you take your T-score and you try to see where you lie. It's very simple, really. So essentially, we want to know what our bone mineral density is, and it measures it at the hip, at the wrist, and at the spine. And the reason we do this test is because we need to know, is a person's bone mineral density compared with the average peak bone mass density of a healthy young adult of the same age? What is it? Because if it's not normal, we need to do something about it. Otherwise, osteopenia will turn into osteoporosis, and before we know it, we will not be able to reverse the process. So a score of -1 or higher is considered normal. Between -1 and -2.5 is considered osteopenia. And of course, less than -2.5 is considered osteoporosis. So what do we do to prevent it? Any woman over the age of 50 should be trying to protect her bones. She needs to be doing something to maintain bone health, even if she doesn't have osteopenia, even if she doesn't have osteoporosis, because at some point, yes, the bone mineral density will decline because that is the natural aging process. So we have to be doing something actively to protect the bones. So eating healthy foods, rich in calcium, rich in vitamin D. If we're not drinking milk, then we should be taking supplements, because that's where supplements actually do make a difference to boost bone health. Exercise and weight-bearing activities. We don't talk about them enough, but yes, maintaining strong muscles are going to protect your bones. They're going to stop you from having a fracture. Stopping smoking, keep banging on about smoking. It is recommended to stop smoking because cigarettes can accelerate bone density loss. But if we've done all of this, and we do need to do something in terms of prescribing a medicine, yes, there are some medicines, and there are hormonal and non-hormonal treatments. We have estrogens, we have selective estrogen receptor modulators, so they do a very similar job to what estrogen does, but they're not hormonal. And we have the combination of estrogen and SERMs, and we also have a drug called bisphosphonate, which also supports slowing down the breaking down of bone, because that is what bone does. It goes through a metabolism where it's broken down, it's built back up again. So the side which is faster in terms of breaking down is slowed down by these drugs. What is really important to say is that hormone therapy for women who are postmenopausal has been shown to lower the fracture risk, and it is effective in preventing osteopenia, but it shouldn't be the choice as first-line therapy for women who have now been in established postmenopause stage and have already developed osteoporosis, because it is not going to reverse the problem. So we need to be looking at other forms of treatment in women who have established osteoporosis. So in summary, I'm at the end, you're done. You get to go for your coffee. Most women experience menopause between the ages of 45 and 55 years old. And 75% of those women will have symptoms that are going to be because of estrogen deficiency. Hormone replacement therapy, and this involves replacing hormones estrogen, progesterone, and testosterone, remain an effective treatment for menopausal symptoms. It lowers the risk of hip and vertebral fractures, so spine, other osteoporosis-related fractures in women with normal bone density, osteopenia, and osteoporosis. And of course, urogenital atrophy is something that we do need to address. It's common, we do need to treat it, and usually we have effective hormonal and non-hormonal treatments that can be used in the majority of women. Newer therapies are out, I'll go back, and there are many, they're in development, we don't have enough evidence, but for some women, starting a novel new therapy may be suitable. They are mainly for symptoms like hot flushes, so vasomotor symptoms, and we still don't have any non-hormonal treatments that are out there available for preventing bone loss and also for reducing cardiometabolic risk. So that's it. These are my references. Thank you very much for listening.
Thank you, Dr. Mantrali, for the insightful talk. We have a slight change of the schedule. If you all don't mind, we'd like to continue with Alexia's presentation, take questions, and then have the coffee at the end. Is that okay? Brilliant. Okay, I'd like to introduce Mrs. Alexia Bodamido, expert accredited menopause dietitian and member of the North American Menopause Society, specializing in nutrition and weight management during midlife and menopause. Alexia will be speaking to us about menopause and weight management.
Thank you. Jenny? Thank you. Judy? Yep. Oi, ναι. Ένα, δύο. 1, 2, 2. All right. How do I get to my presentation? Thank you. Θέλω να έχω το τέτοιο. Μπορεί να προσπαθήσω να... Okay, okay. Και τούτο δουλεύει, ναι? Ναι? Ναι. Perfect. Τέλεια. Thank you so much. All right. Hello, everyone. I'm Alexia. I am a clinical dietitian. I'm honored to be speaking amongst these amazing women here. I'm honored to have you on a Saturday morning, pre-Christmas, here, wanting to know about menopause. I believe that the more we know about our body, the more we know about hormones, the more we know about health, our surroundings, the better our life can be. And this belief became so much stronger when I had to battle, when Nicholas battled against the Ewing sarcoma 3 years ago. We lost Nicholas 2 years ago from Ewing sarcoma, and this has changed me as a person, as a mother. I have lived in a survival mode for years, and I have found out that all we have is now. Let's make this now work for us. I'm going to try to do that for us here. All right, my mission as these other two amazing women here is to ensure that no woman walks through menopause alone. So menopause to me shouldn't be about struggling. It is not a struggle. When the symptoms of menopause hit, we have to know, we have to be proactive. We have to know, how can I manage this? What can I do to live
a better life. There are some general misconceptions, and Dr. Mantrali's touched upon this. There is no blood work, there is the test. We saw the graph that Dr. Joyce showed us earlier. In these perimenopausal years that might take many years of our lives, we have estrogen and progesterone fluctuating even in a day. So how can I have a blood work, a blood test that will show me what's going on? And then the other one is weight gain is only due to metabolism changes. We'll see in a minute how metabolism changes and why that happens. We'll also see that menopause does not end at some point. Menopause to me is a new era that we need to embrace. It's gonna get harder. I think about it as a mountain that I'm going up that mountain. Up on the mountain, I have the word menopause, which is the definition of 12 anovulatory cycles, so no periods. And then it goes downwards. We have the happiness, the zest, right? But it's a whole era of our lives. It doesn't have a beginning and an end. Diet and exercise no longer work. No, I am a big believer that number one tool in everything is diet, of course. And then, is it different from what I did before? Is it different? Is the methodology different when it comes to diet and nutrition from what I did in my 20s or in my 30s? Yes, it is. Is exercise different? Does the workout need to change to facilitate that health and keep that health going? Fasting is not the answer. We're going to talk about why. And then symptoms won't just go away by themselves. We won't just sit and wait as our mothers did and not talk about it until those symptoms go away. Why? Because now we're learning what we can change, what we can do. So as previous speakers pointed out, hormone shifts in menopause, they will touch upon hair, skin, bone health, metabolism, hormone regulation, brain health. We know that as estrogen and progesterone is fluctuating, then serotonin, the happy hormone, is also interrupted. Cortisol, the stress hormone, is also associated with that change. Insulin resistance, we see a great percentage of women going into an insulin resistance state, and we're going to talk about what that means. And then we have melatonin, the other hormone, the sleep hormone that gets interrupted. So we can see that two hormones are changing, and then the whole hormonal system gets changed as well. This is the graph that we saw before. Dr. Mantrali, yours was much better than mine. But it shows that, you know, it can touch upon every system in woman's life. So we can anticipate headaches or hot flashes. We can anticipate hair becoming thinner. We can see that many women are losing their tooth, and they're wondering, does that have to do anything with menopause? We can see the skin becoming drier. We develop a rougher texture. I have a client who says, and she laughs upon it, everything just drops. So the skin drops, the breast drops, just everything starts going down, which is true. You know, nipples become smaller and flattened. We have a great risk of cardiovascular disease, osteopenia, osteoporosis, breast cancer. And this is actually the things that are gonna be as we're going down that mountain. And this is actually the chronic diseases that we wanna prevent. So yes, I wanna look thin and nice. I wanna have energy as I'm in my 40s, 46 right now. But I care a lot more about being healthier and independent. Americans call it age gracefully. Whatever it is, I just want to be independent, and I want to live the best life that I can. Why? Because every now matters. Abdomen loses muscle tone. We'll see why. Vaginal dryness, itching, shrinking, bone loss, osteopenia, osteoporosis. I think Dr. Mantrali's, we should be doing DEXAs as the Americans started doing and the Canadians a lot earlier than the 50s. Do I want to be proactive? Do I want to know where I stand before I get into that osteopenic scenario? It's a question mark, yeah? Yeah, I see you want to talk about this. Stress or urge incontinence, body and pubic hair becomes thicker and darker, backaches, it's one thing that we see a lot. So many symptoms, 46 of them are recognized from communities, menopausal communities. And I want to say that symptoms are fluid. So, women expect to see a number of symptoms in perimenopausal years and then others as we get into menopause. What I see and what I read in the literature is that these symptoms might fluctuate throughout these years. Yes? However, what did I do wrong? Yeah. However, what I was taught to do, and I was in my most difficult years when Nicholas, we were abroad and he was struggling, I had to work. And I got myself into this menopausal clinic where all I did was seeing menopausal women. And then I had a couple of professors. One is Dr. Stacy Sims. All she does is she produces research on women. She's eager to know everything that has to do with women. And that was an eye-opener for me. So I left Cyprus feeling that I was underserving women when it comes to nutrition, and it's the truth, for an amount of time. And then when I was there, I was like, ooh, that's what we should be teaching women. So we are grouping symptoms. We have a questionnaire, and we are actually getting those answers down. And I was so glad for the first, and I've presented many times in Cyprus. It's the first time that I feel, yes, this is my group of people that I want to be presenting with. So if I can't tell on a blood work what's happening, but I have a client, a patient who is telling me that, hey, something's changing, I need to record, note somehow where to start from. And that's what we're doing. We are taking down the questionnaire and then we're grouping that questionnaire depending on the responses so that we get an idea where to start working on. Do I start working on the gut first? Do I start to work on that inflammation first? Do I start working on that brain fog first? So the diet won't change that much, but it's important to be answering to the symptoms of now. And we can do that when it comes to an individualized nutrition plan, right? So what worked before no longer works. So when I stepped my foot in that clinic in the US, in Miami, I read this. And I thought, yeah, nothing works. I feel it. I think it was 36. I'm 46 now when I stand in front of a podium to do a presentation. I was fluent in my presentation. And I had this brain fog. There was this one word, that amino acid, that I had to talk about, and I froze. And I got out of that, and I talked to my dad, and I said, what's happening to me? Am I having dementia? Well, what is wrong with me? A few years later, I knew that that was my first episode of brain fog. Yeah. So eating less is not our solution. We'll see why. I see women in my office every day eating 1,200 calories, skipping breakfast, trying to work it out with less calories than before. We'll see why that doesn't work. Identifying what symptoms bother us is key, as we said earlier. Our gut health is a key to manage weight and visceral fat. It's also important. I think we know a lot about the gut, but not enough. And we're not giving it the proper attention when it comes to nutrition. Whereas to me, there is an axis, and it's proven right now scientifically, it's the brain, gut, and ovaries axis. So we have to take care of all three and see the body as a whole, right? Sleep, very important. It has to do with weight management. It's interrelated with cortisol. We have the 4 o'clock club of women. We just wake up in the morning, 4 o'clock, we sit in the bed. We might go back to sleep, but we might not. It's an actual thing happening. It's not something we're imagining, right? And then how a holistic approach is the way to go. And I'm super glad because I see women stepping in my office going, hey, I'm being dismissed by my gynecologist. I go there, I talk about this, and he tells me, well, we're getting into menopause. I don't know when, but it's getting there. No, I want to know how this is happening. I want to know what are these solutions that I can take upon. So let me guess. We're eating healthier than ever, it doesn't work. We're trying to move more, it doesn't work. We're still gaining weight mostly around the middle. We have tried fasting, we're tracking calories, we're cutting carbs, we're reducing sugar, we're walking more, yet nothing seems to work. This is what I get every day in my office. So, let's clarify two things. We're not imagining anything. Okay, this is a real story and it's happening to us. And it's not our fault. Okay, menopause, we heard it earlier, will change our body in many ways. Most people, especially I think in our culture, in the Mediterranean cultures, we tend to overlook it. We like to put things under the carpet. We don't like to talk about it as much. And then we think, oh, it's the husband, I'm bored of him. It's the kids that are growing. It's my mother that is growing, whatnot. Whereas the changes are coming from inside. There's also changes outside, but the changes are coming from inside. So how we regulate our hunger, how we store our fat, how we build that muscle changes, and how we respond to stress also changes. So what is really happening? We know that from perimenopause to menopause, our body's going to go through profound hormonal changes. It will impact everything. And this is the stand by the North American Menopause Society. It's been 5 years that they've been trying to get out and put some literature and facts out there. And we've managed to do it. And I'm glad to be a part of that board as well. So declining estrogen levels during menopause are associated with increased abdominal and visceral fat, which is more metabolically active and contributes to increased risk of insulin resistance, cardiovascular disease, and inflammation. And let's just explore what this means for us practically. So what is visceral fat and why does it matter? So there is two types of body fat. There is the subcutaneous fat, that's pinchable fat, that is just under your skin, your hips, your thighs, your arms. And then we have the visceral fat, so the deeper fat stored around the internal organs. So that goes above the liver, the stomach, the intestines. And then before menopause, most women tend to store that fat, the first one, the subcutaneous. And the subcutaneous fat responds to a caloric deficit. So if I decide today that I want to go in a caloric deficit, I'm going to have an impact on the subcutaneous fat, but I won't be having an impact on the inflammatory fat, on the visceral fat, which decides to go up as estrogen and progesterone are declining. So before, it used to be in activity in our metabolic years at a percentage of 5%. Now it just decides, no matter what we do, to climb up to 25%. So, no matter what I do, even if I keep that weight off, that visceral fat is going to show up. Things change. So during perimenopause and menopause, the body begins to shift fat storage in the abdominal cavity, and that increases the visceral fat. And that visceral fat is not driven by a caloric deficit. And that's why we need to talk about this new methodology. What can we do different in nutrition? It's influenced by those hormonal shifts, by inflammation, of course, by the chronic stress, by the poor sleep, and the unstable blood sugar. So the visceral fat accumulation during the menopause occurs independently of overall weight gain. So estrogen loss appears to shift fat storage to the abdominal area, even when caloric intake and activity remain the same. I say this 2 times, 3 times, because I think it's really important to understand what's changed right now. So the old strategy said, cut calories, skip meals, do more cardio, right? Whereas now that doesn't work. Why? Because lower estrogen makes our body more insulin resistant. What does that mean? So every time I eat, in very simple words, glucose goes up in the cell, insulin, it's a hormone, comes in the cell, glucose goes down, and that makes us metabolically active. Right now, 7 out of 10 women will be metabolically resistant, meaning they're not going to be fat, they're going to be metabolically resistant. Insulin won't be getting in that cell as it used to. And that causes that insulin resistance might cause weight gain and that visceral fat to increase. Also, there's another thing happening. Women, we have testosterone as well. And that, it's dictated by age, starts going down, which changes our muscle mass. Our muscle mass is our metabolic currency. So not only estrogen and progesterone are playing their game, testosterone is also starting to decline, and we're losing that metabolic activity in the muscle. So muscle mass naturally declines, slowing that metabolism. Cortisol, as if that wasn't enough, cortisol becomes harder to regulate, and it's making our body hold on to more fat. And then we have the stress, the poor sleep, the under-eating. All those will increase the fat storage signals. So we're not imagining it, we're not lazy, and we're definitely not broken. We're just changing. So we are operating in a different hormonal environment, period, okay? So we need a different strategy. When we work with the hormones instead of against, then everything will change. So that's what we try to do when they come to my clinic, work with the hormonal changes. And that it's different for every woman. Individualizations here plays a big role. So I'm going to do reverse psychology here because I think that works more. So instead of telling you, hey, you know, all the things that you do right, I'm going to jump into all the things that we do not do right. So what is number one common mistake that I see in my office? They are eating too little. This is the most common thing we fix first. So most women come in in my office and say, hey, listen, I am just running in the morning. I am grabbing a cup of coffee. I might have a granola later at the office, and that's that. Ooh, big mistake. We'll see why. By dinner, cortisol has been spiking all day. Not only that, glucose is just going up and down, up and down. You can focus, the energy goes down, 3 o'clock, you just want to drop everything and just go to bed. Inflammation is trending upwards this way. Worst part, we think that we're eating less. And most of them tell me, hey, but I'm not hungry. Guess what? We're trainable creatures. Whatever we decide we put in this head and we give it competition, the body will accept. What do we need to do? We need to prioritize protein, which means having enough protein in every main meal. If there is one thing that you get from me today, this is the one. Okay? We're aiming for 3 main meals. You're going to hear this over and over today from me. And we need enough protein. Now look at this. Peanut butter, which is mostly fat, 2 tablespoons, it just gives us 8 grams of protein. We want to be aiming at 15 to 35 grams of protein per meal. Right? So if we're having peanut butter, I'm just saying because I like that, then we're not hitting the protein that we need. And then here goes the Greek part. So I'm going to have a yogurt. Cypriots love their yogurt, and I do too. But look at this. Many women will use 100 grams of yogurt because they're trying what? To lose weight, right? Thinking, oh, it's plenty. But that's only about 8 to 10 grams of protein. So you need close to 200, 250 for a solid protein base. And then many of them will go, hey, I'm just going to have a protein bar, very trendy, happening, a protein shake, which is going to be often 10 to 15 grams of protein, mostly carbs, mostly fillers, and then it just won't fill me up. Or the other thing that I see, I'm just going to have a salad. I just have a salad or maybe a burger, which is going to be the size of a palm. This is what we talk on our 25s, 35s, on our 30s, right? And that's going to be less than the amount of protein that we want to eat. So 60 to 80 grams of chicken, so the size of my palm, will be 15 to 18 grams of protein. If I want to activate leucine, isoleucine, and valine, 3 amino acids that can talk directly to the muscle, and it's the exogenous stressor to tell my body metabolically, hey, you're still here, we need to aim for those 20 to 30 grams of protein. Yeah? And I need to be repeating that on my 3 meals. I eat fruit and vegetable all the time. Well, congratulations, we are in the Mediterranean. If we're not eating fruits and vegetables here, who is? The British? You know? Sorry, Dr. Harper. So, mistake number 2. They're eating healthy foods, but their meals aren't completely unbalanced. So they come and say, hey, I'm in a keto diet. Very proud. Very, very proud. I've cut potatoes, bread. I'm not touching the bread anymore. I'm not doing it. Well, hold on. Serotonin, the happy hormone, is declining as estrogen and progesterone are also declining. So I better have some carbs to keep me happy there, to keep my satiety levels happening, to keep me full, let's say. Fasting until noon. No. Unless fasting goes from 8 o'clock in the evening until 8 o'clock in the morning, then anything else that is called fasting is not for us. Cortisol answers to estrogen and progesterone. Estrogen and progesterone are declining. Cortisol is just going up and down whenever it wants. How does that get into a better rhythm? By going out in the mountains, swimming, or eating. So we need to have a clear timing of our meals, and we definitely need to have a breakfast. Picking low-calorie and light options. Come on, people. I mean, let's wake up on that. Let's forget about that light yogurt and that light cheese and whatnot. They're just getting off the fat and they're just putting carbohydrates in there because they have to, keep the taste of it somehow, right? So let's go for authentic, natural things. We have them in this country. Other countries don't, right? And then we're over-relying on processed healthy snacks. Obviously, we grab a bar, we grab a biscuit, we grab I don't know what you want to call it, but it's off a box. My daughter says, if I can't read all the ingredients, that is not good for me. Well, that's a good rule to follow, right? Mistake number 3. I take many supplements. Oh my God, that's my worst part. She comes in, she sits. Alexiamo, I'm not feeling well. And then she puts on my table 12 different supplements. And she wants me to tell her which is good and which is bad. I say, whoa, put the bag in the bag. And let's just talk about the diet. Let's just talk about the workout. Let's just talk about the breathing. Let's just talk about the society that is surrounding you, your tribe. And then let's have a hematology done and see if we want to take those supplements. I don't like Gwyneth Paltrow. All right. Foundation. Okay, this is the answer. We don't just need enough calories. We need enough nutrition. We need to understand how to structure the plate. We need to understand how to structure the day. And we need to be patient. We're not patient. We live in a world that everything has to happen yesterday. Right? Everything needs to happen right now. Even more so if you are in England, even more so if you are in the US or in Canada. Everything happens right away. There is a solution for everything. Let me tell you something. Best things in life need some patience. Supplements. All right. Magnesium. Yeah? Well, it calms the nervous system. It regulates cortisol. It supports the sleep. But it's found in pumpkin seeds, in almonds, in spinach, in black beans, in dark chocolate. I'm a big fan of magnesium myself. And I tend to like to take it from natural sources. I am a big believer that you can take it from natural sources. If that doesn't happen, let's think about the supplement then. Yes? Vitamin B12. from what I see in the office, in the literature, often it is low in women with high stress or poor gut health. It can support energy. It does support metabolism. It helps regulate mood and nervous system function. Do I supplement B12 blindly? No. I want to know what the hematology says before I do that. Can I take it? Can I take it from natural sources? Yes. It's found in salmon, in sardines, in eggs, in beef. Iron, a big one as well. It is needed for oxygen, for delivery, for energy. And then I hear many doctors say, hey, but you don't have your period anymore, so don't worry about any iron, whatnot. Well, literature says that, yeah, there is many women with low iron and that are being menopausal as well. So it's going to give us fatigue, the brain fog, the pure resilience, the stress, and it is found in red meat, in lentils, in spinach, in tofu. Omega-3s, I really like them. They're anti-inflammatory. They can support the brain function, the hormone health. They manage cortisol and insulin. And they're also found in natural sources, correct? They're found in salmon, in sardines, in chia seeds. Oh my God, I love chia seeds. And then walnuts and flax seeds. So what's our methodology? We assess the symptoms, yes? We group the symptoms. Then we assess the diet. What is my client doing right now? What is she missing? We assess the exercise. We assess the sleep. We support the gut. We support the sleep. And we support the recovery. This is the methodology. So there is two main types of fat in the body. It's the subcutaneous fat, the kind that's stored just under the skin. That I can have an impact with a low-caloric diet, yes? But then there's also the visceral fat, which is the kind that wraps around the internal organs. And this is the one that we should be worried about because each one of us will get that elevated at some point. It is different because it does not react to eating less and moving more, yes? And it's largely driven by the hormonal changes. It can be disrupted by gut health and the metabolic function. So what we need to do, we need to calm inflammation and cortisol. When I see an elevated visceral fat, which I can see from my machine, it's a basic machine that I have to do the weight there, the metrics, the anthropometrics, but also I can get it from the answers from the questionnaire. So I need to see how do I calm inflammation? Can I put cortisol at bay, let's say? So you can also lose weight if you're stressed, if you're inflamed, right? So we need to focus on real food. We need to focus on balancing the blood sugar, consistent meals, the nutrients, and to support that nervous system. We do not want detox teas. We do not want elimination diets. You see how much I was impressed. Just reducing the internal chaos so that your body stops holding on to that fat survival. Yeah? We need to support the gut. This isn't just about bloating. Potamides will tell you, my father, he's a gastroenterologist for years. I think he's one of the oldest here. He'll tell you, he will see women that are menopausal every day. 9 out of 10 will say, doctor, I'm bloated and I don't know why. Right? Here we go. Your gut impacts your energy, your hormones, your brain function, how your body handles food. So we need to rebuild that. Not with endless supplements, but with the fiber. How can I incorporate more fiber in my day? Step 3, we balance the meals. Yeah? We're not just eating healthy. We're not cutting calories. We're making sure we have enough protein. We have the smart carbs. What are the smart carbs? Anyone? Yes, that's a smart carb for sure, and my favorite one. If it's whole wheat pasta, it's even smarter. Why? Because it doesn't have a high glycemic index, and it doesn't impact my glucose as white pasta would do, which we love, right? I'm sorry? Or vegetarian pasta as well, even though I'm just going to comment and say that there is a lot of leavening agents in that. So in order to enhance the taste, they just have to put different things in it. But it's a good option. What's another one?
Brown rice.
Thank you. Brown rice. What's another one? Yes, baby. Thank God. Beans, lentils. Do you have them? Do you have those under the umbrella of protein? Take them out fast. Well, take them out fast, because the biggest percentage, when you look at it, when you do the analysis there, what is going to be? It's going to be carbohydrates, not protein. It's vegetarian protein if we bind them with the correct other carbohydrate. So in Cyprus, we eat the lentils with rice forever and ever. We love that recipe. So rice has incomplete protein in it, right? Lentils have incomplete protein. Together, they bind and they make complete protein as it will come from meat. But I will need 3 cups of that to match the chicken's protein. And I'm sorry to say this, I sound a bit American on it, but this is what we need right now. We need to be pairing our vegetarian options with a true protein. It could be walnuts, it could be almonds, it could be yogurt, it doesn't really have to be meat, right? Step number 4, move strategically, not excessively. I have so many women coming in my office, they want to work out every day. So they go to the gym, they come back and say, oh, I'm so tired. Recovery doesn't happen as it used to. We need the breaks in between those sessions of exercise. And please, I don't know if there's a Pilates instructor in here. I hope there isn't one, because I'm just going to say, we need to start lifting. I love Pilates. It's a medicinal workout. I absolutely adore it. But are you lifting? Are you lifting weights? This is the other exogenous stressor that is going to talk to the muscle and say, hey, I'm still here. What was number 1? Protein. Protein was number 1 stressor that is going to talk to the muscle. What is number 2? Lifting heavily. Come on, people, wake up. Right? All right? So we do it consistently, okay? And we try to stick to it. We don't need to do it all at once. We don't need to start lifting today. I can't go from doing nothing to lift 50 kilos, let's say. I have to work towards that direction gradually. I can't go, having 3 main meals with 30 grams of protein overnight. I have to move towards that direction strategically. Yes, Dr. Effie, I agree with you, and your graph was better. So holistic approach, Dr. Joyce said it earlier, the practices that we have, the use of exercise, the nutrition and the food, the herbs and the supplements, the sleep, the community. This is the holistic approach. This is the plate, yeah? So we need to be 40 to 50% protein, because that's going to boost our metabolism. We want the vegetables. We definitely want the vegetables. That's the anti-inflammation right there. That's the phytoestrogens right there that Dr. Effie was telling us earlier. We want the healthy fats, the olive oil, if you can find it in this country. Can you find olive oil in this country? I don't know. Healthy carbs, because the British thinks we have, but we don't anymore. Healthy carbs. We talked about healthy carbs. Eat the brown rice. Eat the whole wheat pasta. Eat the legumes. Eat the beans. Eat the chickpeas. Right? Eat the whole wheat bread, the sourdough bread, and the whole wheat bread. Eat the Zea bread. Eat the oat bread, for example. Low carb vegetables. When they call me, can I eat as much broccoli as I can? If your intestine can take it, yes, go for it. Can I eat as much cucumber as I can? Yes, if you like it, go for it. But we have to bear in mind that gut is right now in an underactivity. What's happening is that we have receptors of estrogen in our gut as well. And because estrogen is not moving in our body as it used to, gut will be also affected. So I can't be eating that fiber as I used to. Do I want the fiber? Definitely. But I need to add up on that fiber, increase that fiber very, very gradually. Otherwise, I'm going to get bloated, I'm going to get gases, I'm going to get constipation, I'm going to get diarrhea, so on and so forth. And I want to individualize. No one is the same. So gut health, important. Sleep, cortisol, nutrition, pelvic floor, important. Inflammation, we are in an inflammatory state right now, whether we like it or not. It's gonna simmer down. We're going up the mountain. And the road is better. It's not that bumpy when we're going down that mountain. But we need to know how. I have a podcast as well, and I should get you on that podcast. It's called "'Cause Every Breath Counts," and it does. And this is Nicholas.
Thank you very much for all the super useful tips. We have coffee. I'm sure all of you would love a coffee. If you do have questions, we'll take them now. So whoever wants to go and grab a coffee, please feel free. If you want to ask your questions, you can stick around for a little bit, or you can ask our speakers outside at the coffee. It's up to you.